all, and welcome to What is This Shift? I'm your host, El Renee. I'm an LPN of about a decade. I'm in my decade year now. And today, I need to do my disclaimer really quick. Any of the views and opinions expressed here are solely my own and do not reflect employers from past, present, or future. That being said, let's head into episode 3. So episode 1, I talked a little bit about nursing homes, how they were created, why they were born. And then in episode 2, I discussed licensed practical nurses versus registered nurses and why that role of LPN was created, as well as the CNA position, the certified nursing position, and briefly touched on the differences between them all. And now I want to talk about the different types of facilities, where it is that we work in long-term care, what you're going to find. Because I think in the general public there's confusion, but there's definitely confusion amongst us all that work within this system. And I think it's really important for the backstory to lay a foundation. You kind of have to educate people on the different things before you can dive in and get into the drama, if you will. Because it's important to know the distinctions between the different types of facilities and the different places that we work in terms of long-term care, because there's definitely differences, and yet the lines are being blurred every day. And in order to discuss that, you still have to understand what the hell that even means, okay? And also, in medicine, period, we have our own language, right? Medical terminology, there's a lot of lingo, there's a lot of slang, and there's also a shit ton of acronyms, okay? There's an alphabet for everything. It's kind of like the government, the CIA, the FBI, okay? We are the same way, if not worse. So you hear these terms thrown around a lot, and then you have the alphabets, and then they're kind of turned into their own word. So, like, for example, a skilled nursing facility, it's called a SNF for short, SNF. So, you're going to, assisted living facility is an ALF, ALF. So, let's get into it. Let's talk about the ladder, if you will, of getting out of the hospital, and then now you're in the long-term care environment, the arena, the extended care, however you want to call it. What happens to you then? So let's say you're in the hospital, you're in ICU, you're better, so now you're going to go to a step-down unit. That could be a tele unit, a telemetry, or med-surg, which is short for medical surgical. I'm not talking about hospitals. I'm not an RN. This is all long-term care based, but I just want to give you kind of a map, kind of an idea. So once you've stepped down, now you're ready for discharge, right? You can discharge immediately out of those units. If you're fine, you can go home. But sometimes you can't, because you might really be medically complex. So you would probably go to what's known as an LTAC, which is long-term acute care. And that has nothing to do with nursing homes or assisted livings or any of the normal things that you would associate with the word long-term care. But it is long-term care in the sense that you need medical treatment for a long time. Long-term care, LTACs are very rare. They are hospitals. They're not nursing homes. And I say they're rare because there's only 400 of them in the nation. Most of them are anchored within a hospital. They are, the patients need to reach a certain criteria, okay? They're usually ventilator patients, trachs. They may be in a persistent vegetative state. They might need long-term care IV antibiotics for things like, post-septic shock or osteomyelitis. They have complicated wounds, maybe multiple wounds, maybe deep, like stage 4 wounds. They need wound vacs. And their care may be weeks to months long. Complex medical needs, and the criteria is that they need a daily MD involvement, daily medical management by a physician. So, like I said, there's only 400 of them. There's only 6,000 hospitals in the United States, which sounds like not a lot, right? Because I mean, it seems like every town has a hospital. So how is that possible? But it's true, and we're losing them every day. Like, we have about 400 that are now slated to be closed due to this big, beautiful bill, Medicaid and children's insurance cuts. We're going to lose a lot of rural hospitals. That's a whole podcast episode in and of itself that I probably won't even cover because it's political, and I don't want to go there because that's not the aim of my podcast. I'm really not trying to get political here. Unfortunately, politics does affect healthcare and vice versa. So I will touch on some of that in terms of how it affects long-term care, but I'm getting way ahead of myself. Like I said, right now I'm just trying to lay the bricks so we can build up to what we need to do to change, because that's why I'm doing this. I'm not getting paid for this. Oh, by the way, April Fools, I said this was going to be ready. A new episode was going to be March 31st. Yeah, that didn't happen, and I now know moving forward I'm not going to give a specific date because yesterday I had a really bad day and I just wasn't feeling it. So I didn't have the headspace to do this. But I'm doing it out of my heart, because I really feel very strongly about advocating for change and being the change I wish to see. And the only thing I have is my voice and my vote. That's it right now. But if I can gather enough people together and gather around the campfire and tell these stories, maybe we can start to get some momentum. Because the more of us that speak out, and we are speaking out. I mean, I see the comments all over the internet on different, various venues. We all know. We're all preaching to the choir when we discuss the issues happening in long-term care, but we need to bring it forth to the public. The public is woefully ignorant to what happens, and that's okay. They don't need to know everything, but I promise you, when they need us, they're very confused. They don't know what to do, and so I hope that my podcast can help families and the general public as well as us, each other, the people working within the community. So if you are a family member or just a member of the general public who's considering putting a loved one in long-term care, welcome. And I hope that this will be of some service to you. So getting back to that, there's 15,000 plus nursing homes, by the way. So out of all of the healthcare entities in our country, nursing homes are the most, and yet they are the least recognized and the least cared about. But again, I'm getting ahead of myself. So now you're ready to be discharged from the hospital, but you still have some stuff going on with you, right? But you're not critically ill. You don't need an LTAC. So, but you still do need medical care. Now, maybe you were in the hospital because you had a surgery or you broke your hip. So you would need some sort of rehab, right? Rehabilitation. You are not needing long-term care housing. You don't need long-term medical care. You just need help getting over this hump of whatever illness or surgery you may have just had, right? So you're going to go to rehab out of the hospital. Now, if you need intensive rehab, you're going to go to what's called an inpatient rehabilitation facility, or an IRF, an IRF. And yes, this is high-level rehab, and again, usually a hospital or hospital-based, and it requires 3 hours of rehab a day. So whether that's physical therapy, occupational therapy, or speech therapy, and you have to be able to actively participate. So you're not going to be in a coma going to this, but this may be because you had a stroke, or there's a spinal cord injury, or brain injuries, or there was a orthopedic surgery. So it's more intensive rehab than you're going to find within a SNF facility. What's a SNF facility? That is your nursing home. Now, people use the term nursing home as a kind of a blanket thing to describe where people go, right? Like people call it the old folks home, the retirement home. There's a lot of different ideas of what a nursing home is. And a nursing home really, it's known as a SNF now, a skilled nursing facility. There is a nursing home within a skilled nursing facility. Now, some of this is going to get confusing, so I'm going to try to unconfuse it for you. A nursing home is just, that's all it is, right? But those don't exist anymore. They are known as skilled nursing facilities because within that skilled nursing facility, there are different areas or different units that deal with different issues, just like a hospital, right? So hospital, you have like labor and delivery. That's where people are going to do babies, have babies. You have the surgical unit. That's where people are having surgeries. You have the ICU, the intensive care. You have the ER. So just like a hospital, you have different areas of care within one building. So that's why it's called a SNF, because you're going to get skilled nursing, you're going to get skilled care therapist, respiratory therapist, occupational therapist, all of those things, speech therapy. So it's a SNF. So moving forward from now on, when I say SNF, that is synonymous. That means nursing home. When I say that you have a nursing home within the SNF, I'm getting to that. But right now we're talking about you're coming out of the hospital and you need rehab. So if you don't need intensive rehab, you're going to go to the SNF and you're going to be on the rehab hallway. Now, from my perspective, and I've been in a lot of different SNFs, there seems to be two types of models. It's either like a ranch style building where it's just all one floor and you have different hallways is what they're called. So the units are on different hallways, or kind of like a school, right? Or you have a vertical building that has floors. So 99% of the time, your rehab unit or hallway is going to be on the first floor. And it's known as a subacute. So if someone says, oh yeah, I work in the SNF and I'm in the subacute, you're in the rehab unit or on the rehab hallway. What does that mean? That means it's less intense therapy. The patients are weaker and they still are getting nursing care as well as rehab. It's only 1 to 2 hours of therapy, like for joint replacement, or maybe, you fractured something. So like you broke your leg, even pneumonia, right? Pneumonia can weaken the hell out of people. So you need to rebuild your strength. So they typically stay for 10 to 30 days. And this could be any age group as well. This isn't just old people. So that's, I think, another thing that people get wrong is that they think that nursing homes or SNFs are filled with just elderly. And that's not even true. Okay, so I'm going to get to that. But on your subacute hallway, your rehab hallway, you're going to see all ages. But typically, you're going to see older people. But they're the 40s, 50s, 60s. I mean, that's considered pretty young for long-term care. And they're with it. They're alert and oriented times 4. They know what's going on. And they didn't choose to be there, right? They're not sick. They don't really need any medical management. A lot of them, it's like, yeah, I take a blood pressure pill. That's it. But they're definitely going to want those pain meds. Okay, so a lot of rehab is also pain management. But they're not really medically complex typically. So they're very with it. And as a result, they care about their environment. And it's also known in some places as the Medicare hallway. And I say that because if you don't have commercial insurance and you are of the age to have Medicare, Medicare is going to pay for it. So commercial insurance pays for it too, your PPOs. Probably your HMOs do too. I don't know. I haven't dealt with an HMO in years, but I'm going to assume that if you get a referral, it's paid for. But don't quote me on that. I don't know. I have to do a little bit more homework on the insurance stuff because I can tell you how most of these places are getting paid. But everybody else in the SNF it's covered by Medicaid or private pay. But for this hallway, it's the Medicare hallway. That's why there's typically more charting and documentation that needs to be done by the staff. But as a result of that, they like to market this hallway because it's very competitive with all the places in the area, right? Because people can choose, especially with that private insurance, where they want to go, right? So they have to make it an attractive place. So typically that's going to be the nicest area of the entire building, whether it's a vertical building or a ranch style building. It's going to be really nice. And there's a place 5 minutes away from me that refers to itself as a medical resort, and it looks it. It's got, beautiful chandeliers, it's gorgeous. It looks like you've walked into a 5-star hotel. However, if you read the reviews and you see the people on Facebook talking about it, its reputation is terrible. In fact, the hospital across the street is like, yeah, nah. So, they're not allowed to recommend or send anybody specifically, but they have their favorite places. Trust me. I'll get more into that later, but don't be deceived. I call it lipstick on a pig. Just because it looks pretty doesn't mean that it's not having the same problems, if worse, than any other sniff. But those are your areas that are going to look really nice. So here's a pro tip. If you are looking to place your loved one in the long-term area, not the rehab, but like for a place to live specifically, you insist on going to the other hallways, because they're going to take you on a tour through that rehab unit or that rehab floor, and that they're going to leave it at that. And if you go to those other hallways and you smell urine, or you see people yelling out and you're looking for staff and question that. Unfortunately, you're probably going to see all of that. But if you smell something, no, unless you're literally walking past a room where the CNAs are in there actively changing someone, if there's a lingering odor, no. Same is true if you're going on a job interview. Ask to see the entire place. Get a tour of the entire place. You want to see the dining room. You want to see the rehab area. You want to see it all, because that paints the real picture. Don't let them just sell you on one particular area. But anyway, like I said, people are there short term. So if you work on that hallway as a nurse or CNA, you're dealing with less people. I want to say the average amount of patients, and they're called patients when they're on rehab, would typically be, I want to say, an average of 14 to 15, which is still, to me, kind of high, because sometimes they're not just an easy blood pressure med. They are medically needy, but it's way better than the other ratios that you're going to see. But they, what was I going to say? Yeah, it's only like 15, but they're more demanding. They're more needy. They do want those pain meds on the hour, every hour, whatever the, it's usually 4 to 6 hours, but you know what I'm saying? Like they are more demanding. They're alert and oriented, so they're more prone to be complaining, whether it's about the food or somebody not answering the call light immediately. So it's more demanding on a different level than maybe some of the other areas of the building, right? But it's the nicer area to work. Oh, that's what I was saying. So you might think, oh, this is not bad for a nurse or a CNA to be working with this ratio of people. But when you factor in the demand and then the fact that there are constantly discharges and admissions, then it gets sort of intense, because not every place has an admissions nurse or a unit manager that helps deal with that. And those are for later topics. But that's your nice area of the SNF. Now, I'm not trying to say that every other area is a disaster, but when you go into the long-term care hallway, it doesn't typically look as nice. It's not as fancy, and it's not hotel-like. It's more institutional-like. It's more hospital-ish-like. And you could argue that a lot of that is for sanitation purposes. When you have 30 some people on a hallway living there permanently, and they're maybe incontinent, or you got a lot of medical stuff going on, probably having carpeting in the hallway is not a good call. Now, I've seen carpeting in the hallways on some places, but many places don't have that. So they're just not as nice looking. That doesn't mean that they're not clean. It doesn't mean that they are not giving quality care. It just means that that's not their selling point. They're not selling people on this, because people typically end up on the long-term care hallway out of necessity, not because they're shopping and this is where they want to be for a short period of time. So that's the basic difference. So these places don't invest money in making it a really nice area. So aesthetically, it's not going to be as pleasing. But it doesn't mean that there's not being care given. Okay, so I want to make that clear. But it's the long-term care hallway because that's where people live. And now they're not patients, they're residents. And they are going to stay out the rest of their life there. And they can be of any age. You can have people who have disabilities and handicaps, and they are total care. They need help from the staff. I've seen people as young as 22 on a long-term care hallway. They can be medically complex. They might need G tubes. They might need Foleys. They might need oxygen. They might have ostomies. They have things going on with them. Some of them even have chest tubes, peg tubes, J tubes. I've seen them on wound vacs. I've seen them with the, I forget what those are called right now. I'm drawing a blank, but the thing that massages people's legs, that machine, it's a thing that you put on people's legs and it massages it for them to keep the blood circulating to prevent a blood clot, a DVT, that type of thing. Yeah, you're going to see that. Should you? No, that's a different topic. That's a different episode, and I'm going to get to that. But that's what's known as a nursing home right there. That hallway is the nursing home part, because you're not supposed to need skilled stuff, but they do, okay? So, but that would be your retirement home. That would be your old folks' home right there. They're not sick enough, right, for an LTAC. They don't need rehab. They have chronic issues. They're not strong enough to be home. They can't walk safely or without some sort of monitoring, or maybe even some DME, which is durable medical equipment like your walkers or wheelchair. They definitely need help managing their medications, and they need help with ADLs. ADLs is activities of daily living. That's getting, bathing, dressing, eating, meal preparation, laundry, things like that. And they can still be medically fragile. Now, all that stuff that I mentioned about the criteria of an LTAC, you might say, I've seen that in my long-term care, my hallway. I've seen that in my nursing home. We have IV antibiotics. We have PICC lines. We have wound vacs. We have, even trachs. And you're right. I personally, too, have seen that, even including at one SNF I worked at, I picked up an agency shift. They literally, and it was in the middle of Chicago, they had one floor that was literally just ventilator patients. It wasn't an LTAC. It was just turned into an LTAC hallway. And, of course, it was just RNs and respiratory therapists. But, what? So, anyway, getting back to the long-term care hallway, yes, those people live there. That's why they're referred to as residents. I think I've said that before. It's just like if you live in an apartment building, you're considered a resident there. So now let's say somebody graduates from rehab hallway. They get to go home. But home for them, if they're seniors, and believe it or not, there's a lot of 55-plus communities, especially in Florida, holy cow, which blows my mind because I'm over 55, but I don't consider myself a senior, but apparently I am. those are considered independent living communities, and there's some apartment buildings that are independent living communities. So independent living is housing for seniors who can take care of themselves. Sometimes these places have meals, and they have social activities, even housekeeping, but there's no caregivers, there's no nurse, because there's no need for help with daily activities, like like ADLs, and they don't have any need for medical care. And if there's something goes wrong, it's 911, right? But if they do need some help with activities of daily living, then they wouldn't go to an independent living. They would go to an assisted living facility, also known as an ALF. So we got a SNF and an ALF. A lot of people in the general public might confuse the two or refer to both as a nursing home. An assisted living is not a nursing home, and a SNF has a nursing home within it. There we go with the acronyms again. In my state, I'm in the state of Illinois, most assisted livings, in fact, all of them, are private pay. At least I should say in the Chicagoland area. Maybe down southern Illinois, I don't know. But if they can't afford private pay assisted living, then they would go to a supportive living. So now we've got independent living, assisted living, and supportive living. Independent, no need for us. Assisted, they need us. Supportive, they need us. But supportive is paid for by Medicaid. That's the difference. Assisted living's private pay, Medicaid pays for supportive living. Now, I'm aware that some states do have assisted livings that have some rooms set aside for Medicaid residents. So some places do combine the two. They do supportive and assisted underneath the same roof. In my area, they're separated. So an assisted living is defined as a residential setting for people who can't live completely independently, but they don't need full nursing home care. So they need help with bathing, they need help with dressing, they need help with meal preparation, and some basic supervision. Mostly activity of daily living care. Sometimes they need help with medications in some form, but they are supposed to only need medication reminders. Like somebody pops in and says, "Hey, Mrs. Jones, it's 9 p.m. Don't forget to take your, blood pressure pill tonight." That type of thing. They're also not supposed to require ongoing skilled nursing care. What's skilled nursing care? That means the nurse has to touch you in some way, whether it's to change wound care or to, flush a Foley catheter, change your ostomy bag, that type of thing, okay? So I'm not going to get into all that right now because that's for later to discuss, because there's issues there, and if you know, okay? But that's what an ALF is supposed to be. It's basically supposed to be housing with help, not medical care. That's why in assisted livings you often see that the nurses and the CNAs are not even called nurses or CNAs. And to make it even more confusing, a CNA in an assisted living does not have to be certified. They can just be a caregiver. They can just be somebody that comes in off the street and says, "I want to take care of people." They're basically doing the same things that CNAs are doing without the training. Because, yeah, we'll get into that. But many of the staff, they don't even wear scrubs. So you can't even differentiate that as medical people, because you're not supposed to be doing medical stuff in the ALF. It's basically an apartment with support, so they can get help with things that they can't safely do on their own. This is kind of where they go when it's like, uh-oh, mom left the stove on again. That's when families are like, I think it's time for the assisted living. So let's say, though, that they're coming out of rehab and now it's time to go home and they live at the assisted living, but they need oxygen now. Or maybe they still have a wound that needs to be, the dressing needs to be changed on a daily basis or like 3 times a week, and it's complex not complex, but it's wound care, basically, needs to be monitored, needs to be documented on like a wound, then they will have to go on home health services. Home health is basically nurses that make house calls, and they come in and they do skilled nursing. They do sniff nursing, but within a home setting. So, for example, they can insert and flush and take out Foley catheters. They deal with wound vacs. Excuse me, they suction trachs. So in order for people in an assisted living to have, if they suddenly have a skilled need, something that requires a skilled nurse, they must go on home health services. Or the other player in assisted living and long-term care is hospice services. Now, I also just want to briefly say, just because it says skilled nursing, that doesn't mean that your nurses within an assisted living community are not skilled. Many of us have worked in skilled for years and years and years. We come to an AL. A lot of people, this is where nurses come to die. This is where nurses come to retire. And they're not wrong, okay? Because it is less in terms of like what nurses are able to do in an AL, but that doesn't mean that they don't have skills. So I don't want to confuse people and think, well, does mom getting skilled nursing? You mean the nurse at the ALF, he doesn't have skills? No, we have mad skills usually. But sometimes you do have baby nurses that have never worked outside of an ALF, and that's okay because they don't need to have the skills because technically they're not supposed to be doing the skills. So moving on, hospice. Hospice is care for people with life-limiting illnesses. It's focused on comfort, quality of life, and symptom relief rather than curing whatever disease they have. And the criteria to be on hospice is typically 6 months or less to live, or it's the decision to stop aggressive or curative treatment. So, for example, like no more chemo kind of a thing. The goal then is to comfort, not treatment. It provides pain control, anxiety relief, breathing comfort, and emotional and family support. And often they need it more than the actual resident needs it, right? You can also have palliative care, but that's usually offered by the same hospice company because palliative care is a part of hospice. Palliative care is also focused on relieving symptoms and improving quality of life, but they are still receiving treatment for their illness. So, for example, this would be the cancer patient that's still getting the chemo, or maybe they're getting dialysis, having surgeries, and they would still be sent out to the hospital if they were having an acute illness. Basically, the difference there is that palliative care helps you feel better while you're still fighting the illness, whereas hospice is when you stop fighting and you just focus on comfort. And now to further confuse you, the hospice does include palliative care. So, for example, you have someone on hospice in your assisted living, and that hospice resident develops aspiration pneumonia. Hospice will treat it with antibiotics. That's considered palliative. Because they are on hospice, say, for breast cancer, that's not going to be treated due to their advanced age, but the resident develops this pneumonia, you're not going to not treat it. You don't want them to pass away from pneumonia, right? And you want them to be comfortable. Obviously, if you can't breathe because of the pneumonia, you ain't going to be comfortable. So that's why we're doing that. We're treating the people, even though they're hospice, they're being treated. Now, all of this, it's sketchy. And I'm going to get into why it's sketchy in later episodes. But, and let me just say that people can have advanced directives and living wills that would say, don't treat my pneumonia. If I have cancer and I'm going to die anyway and I develop pneumonia, don't treat it. But that has to be written, legally signed document when that person is of sound mind and body, okay? Can't be the POA. It has to be the actual resident, and that has to be in that legal document. That's part of their advanced directives. That's part of their DNR, because under your DNR, there's different, you know what, I'm not going to confuse you guys further. I'll get to that. We'll cover that, because even though people are on hospice, you would think that that means an automatic do not resuscitate. I've literally seen full codes, which means do everything, do all the things while they're on hospice. So anyway, these are the players that you're going to see mostly in long-term care. You're going to see independent living, which really has nothing to do with us because there's no care involved. But that's where your seniors go. That would be more like the old folks' home, right? But you have independent living, you have assisted living, you have supportive living. The two are the same. It's just the payer is different. You're going to have your SNF, your skilled nursing facility, which houses the rehab hallway, the long-term care hallway, and then you're going to have hospice or home health. Now, what did I leave out? Any guesses? Okay, well, I'm going to tell you, I'm going to be a spoiler alert here. In your SNF or in your assisted living, and sometimes in a standalone facility, its own building is going to be your memory care unit and your memory care hallway or your memory care building. And that is where the people who have Alzheimer's or any other form of dementia, that's where they go. And they may or may not have medical needs. It is wild to me after doing this for, many, many years. And not just as a nurse, but just being in healthcare for 40 years, being a hospice aide, being a CNA, being a PCT, and my own father having had Alzheimer's. He actually had Lewy bodies dementia. It is phenomenal to me, and this is purely anecdotal, how healthy physically these folks are, but their minds are affected. But they are often the pillar of health. Some of them don't even take medications, or if they do, it's like one pill. Excuse me, they are usually extremely healthy. So they don't need medical supervision so much, but there's a lot of other stuff going on, okay? You deal with their behaviors. You deal with sundowning. Sundowning is literally that. As the sun starts to go down, like around 4 o'clock in the afternoon, their dementia worsens. Sometimes hallucinations begin. There's more behaviors, and there's a lot of reasons for that. I'll get into that when I focus more on memory care. Right now, I'm just telling you guys what all there is, and then we're going to get into more in-depths about each place and the problems that lie within. But this is where these units are locked. So nobody can get in unless they have a code or a key, typically a code, and nobody can get out without setting off an alarm. So this is for their safety, because these people like to wander and they like to elope, is what it's called. They will try to escape. And it's not even that they're cognitive, like, I need to escape, I'm in a prison. Sometimes they're aware of that, but they just want to go outside. And there's been some news stories about the tragedies that happen when these people are able to get out and they're found frozen to death outside. They are found down the street. I have literally been involved in having to chase 2 residents in my entire career. So unfortunately, it was a good ending. Everybody was okay, and we got them. The police have picked up people and brought them back. I've seen that. So you might ask, how is that possible? How the hell does that happen? Well, I'll get there, but not today. So I just want to leave you guys with a big thank you for listening. And so if I'm leaving anything out, let me know. I don't think so. I think I covered all of the long-term care facilities or services. And there are some companies that are actually mobile physicians. So they're kind of like home health, but home health is mostly nursing care, physical therapy, occupational therapy, and speech therapy that goes out to see the patients So if you're in home health, now you're back to being a patient, you're not a resident. But there are mobile physicians that go out and see people, and they usually take a medical assistant with them. So that's only for homebound people, though, just like home health is. The criteria for home health and for mobile physicians is you have to be homebound, meaning it's not safe for you to leave your home, or you can't leave your home without extensive help. That's the criteria. I'm just going to leave you with that, because the criteria is here. I hope you paid attention to, because I will reiterate them later when I discuss how these criteria are being ignored oftentimes, or how they're finding workarounds, how they're finding loopholes, and where this is happening. So thank you for tuning in, and thank you for supporting my podcast. Have a blessed day.